It is my honor to introduce Dr. Kutsch. A little bit about our fearless leader. He is a retired dentist of 40 years. He's a prolific writer, thought leader, inventor, and researcher in the field of dental caries and minimally invasive dentistry. He acts as a reviewer of the Journal of the American Dental Association and Compendium. Dr. Kutsch is also the CEO and founder of Dental Alliance Holdings, LLC, manufacturers of the CariFree system, and is a scientific advisor of the dental caries at the prestigious Coist Center. We're so fortunate to have him as our fearless leader. Please help me welcome Dr. Kutsch.
Hey, thank you, everybody. And this is going to be a fun morning here, a fun hour. Let me get to my screen, and we'll get started. I think the title for today's presentation is hello. If I could, this bar is in my way. There we go. The title for today's presentation is, dental caries, a whole person disease. And I think that this really sums up what I want to talk about today, that once you get to the point where you understand and you see this disease as a whole person disease, why am I not getting slideshow to work here this morning? There we go. Once you see this as a whole person disease, you get the opportunity then to, treat it differently. And I was spending time with Rella Christensen last week, and, we were talking about this whole idea, and it's really, 20 years ago, once I got my brain around the fact that it isn't just a cavity in a tooth, but there's a disease that's causing that cavity. And once I understood that and started focusing on the disease and trying to figure out how to treat that, it changed my entire outlook on this disease and what I was trying to accomplish as a dentist. So it's really what I want to do. A couple of things I want to do for you today. I want you to start thinking about this as a whole person disease. So instead of seeing a patient that has cavities, I want you to see a patient that has a disease, and it's really our opportunity to try and figure out that disease for that person and to be able to help them become healthy. The other thing I want to do, if you've never done Caries risk assessment before, this is a great program for you. We're going to go just through the basics today, but kind of give you a starting point, that you could start tomorrow in your practice. And you're going to need a Caries risk assessment form, and I'll show you how to get a free one at the end of this. And if you're doing Caries risk assessment already, hopefully I'm going to fill in a few blanks. And if you've been doing Caries risk assessment a lot for like 15 or 20 years, hopefully you're going to see some new science today that will help you, moving forward. When we talk about dental caries, and why am I not advancing? Here we go. When we talk about dental caries as a disease, it's the #1 disease in the world. And, it's a biofilm disease. It's difficult to treat. Dental caries in children is the number 10 disease worldwide. And this is across every age demographic, every socioeconomic graphic, and in every country globally. Dental caries is #1. So it's like, this is the biggest challenge that we have in dentistry. This is excuse me, this is the definition for dental caries. Well, what is it? Well, I like to say that it's a biofilm-mediated, host-modulated disease. And I think you heard Doug Thompson say that about periodontal disease. And I think the same thing is true here. You look at this definition that was published last year by committee. It's a bunch of word salad. Everybody got their favorite important word in. But the important part to understand here is that this is a disease that's biofilm mediated by pH, and your diet and the host, other factors just besides diet, help modulate that. It's a multifactorial biofilm disease. It's non-communicable in that sense, but it's transmissible from like parent to child, mother to child. We have a lot of data on that going back for the last 30 years. But it results in net mineral loss on the tooth and eventually end up with decay. You end up with a cavity in the tooth. The challenge for us as dentists is we get so focused on that surface level. You have a cavity, a lesion on the distal of tooth number 21. We get so focused on that we don't stop and step back and go look at the entire person and go, why does this why does tooth number 21 have a hole on the distal, and what caused that? Because if we can, you know, you're not going to drill and fill your way out of this disease. I tried that for 20 years. I am here to tell you that doesn't work. So what we need to do is figure out why that patient has that decay. And if we can get that answer correct, then we have a real opportunity to help that patient get healthy. And without that correct answer, we're going to drill and fill until they run out of teeth or die. And that's what I did for the first 20 years of my career. I like to tell you that this is a pH-driven disease. This is Philip Marsh. He did the pioneering research on this back in the 1980s, and he's one of my mentors. He's an incredible individual. But what he determined, what it wasn't the sugar availability that was causing the change and the shift in the biofilm in this in vitro study that they did. It was actually the pH. And so this is a pH-driven disease. Well, why is pH important? Well, if you take a look at this, if your biofilm and diet are end up being acidic, but your saliva is alkaline, you know, we should be able to keep this homeostasis or this healthy balance in the mouth. You have this continual process going on in your mouth that's going on right now. Everybody does, of deep periods of demineralization and then episodes of remineralization. As long as that's in balance, you have healthy teeth. The problem is when we get to the point where we have more prolonged periods of demineralization than we have of remineralization, and then we end up with net mineral loss and tooth decay. So if we go back and look at the Stefan curve, you start out in the morning, you know, if the blue line here in the middle of this graph represents the critical pH of enamel, you start in the morning, you have breakfast, you drop below, you go into a period of demineralization. 30 minutes later in a healthy mouth, that recovers. You get back into a period of remineralization, then you have lunch, and then the same thing happens, and then you have dinner, and the same thing happens. And if you look at the area above the line versus the area below the line, you've got more time in the remineralization than you have in demineralization. So here you've got a healthy mouth. You're not going to end up with tooth decay in this situation. The problem is when you just throw 2 snacks a day into this, it changes what's happening in the mouth. Now we've almost doubled the amount of time that we're spending in the demineralization phase and less time that we're spending in remineralization. So it starts to tip out of balance, as John Featherstone would talk about, the caries balance or caries imbalance. We're starting to get into imbalance. Now, if the patient doesn't have enough saliva for a myriad of reasons, it takes longer for that mouth to recover. Instead of taking 30 minutes, it may take an hour or 2 hours, or it may not hardly recover at all. And so now you've got even greater time in that demineralization period than you've got in the remineralization. So hyposalivation is an issue. Then you take the patients who have a bad diet, you know, an ineffective diet, and they don't have enough saliva, they're taking medications. And now you have a recipe for disaster. And that's why you see the patients that you see in your practice, because Americans, number one, most of us have less than ideal diets, let's put it that way. And you know, a lot of us are taking a lot of prescription medication. So those two factors alone just add up to creating huge issues for us. If we look at the current disease model for dental caries, you know, we know that it's a biofilm-driven disease, biofilm mediated. We talk about biofilm dysfunction or dysbiosis. We know that it has systemic effects. We also know that there are hereditary components. So when we talk about that, you know, this is exactly, and you think of another disease like this, and, you know, Doug Thompson talked about that, periodontal disease. It's one of the most common diseases in mankind today globally. So these biofilm diseases are the most difficult to treat. This is Ann Tanner. She's at the Forsyth Institute at Harvard, where I did some of my work early on in dental caries, but she's an expert in biofilm and one of the best in our profession worldwide. And when we talk about these biofilms, when I started looking at this 20 years ago, we were thinking in terms of mutans streptococci and lactobacillus, and I was culturing for those two different, you know, pathogens. And it got more and more complicated. And as we started to understand more and more of the risk factors, it got to the point where that disease model just doesn't even fit what we're seeing or what's going on in the terms of this disease. So now we talk about really the entire biofilm. It doesn't matter if you have mutans streptococci or not. 40% of the children in this country who have severe early childhood caries don't even have mutans streptococci in their mouth. So we know now that there are a lot of other pathogens and a host of pathogens that contribute to this disease. In fact, even what we thought at one time were the healthy bacteria in the mouth or microbes, we now know actually play a role in dental caries as well. When the pH shifts, they join the party. It's one of the challenges that we've had with probiotics as well. But now we talk about, do you have a healthy biofilm? Do you have a cariogenic biofilm? Do you have a periodontal pathogenic profile? So we're starting to look at this. It's not a one pathogen, one disease. So that old disease model, just erase it from your memory. This is really a complex multifactorial disease, and it has multiple pathogens and multiple risk factors. And we're going to go through those today so you kind of have a feel for that. This is Doug Thompson I've been talking about here. Doug, for my dollar, has um, I know Doug has more longitudinal data on periodontal patients that he's treated in his private practice than anybody I know globally, period. And so Doug has a great understanding of periodontal disease, and I really appreciate the work that he's done as well. One thing that we know, and we started seeing these studies out of Japan in as early as 2005, we started to realize it isn't just periodontal pathogens that are found in the heart plaque, on the heart valves and the atherogenic plaque. It's also these what we contributed or believed to be cariogenic pathogens as well, and things like strep mutans still play a role in this study that was just published this last year. Not only was it the strep mutans that contributed to the infection in the atherosclerotic plaque in the heart tissue, but also the sugar intake played a role and was correlated in the study as well. And we now know that strep mutans is pretty much the causative factor in bacterial endocarditis. We also know that it plays a role in the brain. And if strep mutans has a particular gene, the CNM gene, if they're positive with that gene, they can directly invade endothelial cells. And we know that the endothelium is only 2 cell layers thick. And so is this playing a role in atherosclerotic plaque and in heart disease? We don't know that. We certainly have established that with some periodontal pathogens like P. gingivalis. We have that pathway worked out. But here we do know that it is responsible for microbleeds in the brain. So does it play a role in potential ischemic attacks and strokes? Yes, it does. So you can't have an unhealthy mouth and have a healthy body. Having an unhealthy behaving biofilm in the mouth can contribute to systemic effects. You're going to see, this is just a couple of studies. There's a lot that are available, and you're going to see a lot more in the next few years to come as we continue to look at this. When we talk about the potential genetic effects, we know that genes play a role in dental caries as well. This is Alex Vieira. He's at University of Pittsburgh. He's one of the leaders in the world. Most of the major studies that come out on genetics and dental caries, his name is on that paper. And so I had an opportunity to spend time with him one-on-one and learned a lot. So one of the first studies that we saw published in genetics with dental caries is this beta-defensin 1, which is a salivary enzyme excreted by the or secreted by the submandibular glands through Wharton's duct. But interestingly enough, there's 3 different polymorphisms for this gene, and the people that had the G20A copy had 5 times the DMFT and DMFF scores of the other 2 polymorphisms. Just that gene polymorphism alone accounted for 5 times the DMFT and DMFS scores. So we know that genes play a role, and there's all kinds of different genes. There's over 60 now that we know play a role in dental caries. These are the taste genes, the TAS2R38 and the TAS1R2 genes. For the bitter, these kids are sensitive to phenols, cruciferous vegetables, so they tend to prefer sweets. Again, sugar intake we know is related to dental caries. So we know that taste genes play a role as well. And there's, like I said, there's over 60 at this point in time. So that gives you kind of just a brief view of our current disease model. One thing I want to introduce to you is the term caries risk management, and that's really what we're trying to accomplish with caries risk assessment. And I want to introduce you to the term P4 dentistry. This was first coined by Leroy Hood back in 2010, a physician talking about we're now diagnosing and treating patients literally on a molecular level and a cellular level, and that medicine should now be predictive. The 4 Ps, it should be predictive, it should be preventive, it should be personalized, and it should be participatory. And as I sat and listened to him lecture, I thought, you know what, that really describes caries risk management. And we're talking about an approach to dentistry that's predictive, preventive, personalized, and participatory. So I want you to kind of just put those in, file them back here away, but I want you to continue to think about that as we're moving through this. I had the good fortune of being involved early on with the Canberra group, and I have to tell you that, early on, we made this way too complicated. And the reason that, not every practitioner in the country right now is doing Caries risk management is because we made it too complicated out of the gate. And one of the things that I started to see over a period of years was that I would see dental caries come in a regular pattern. They either had not enough saliva, or they didn't have a decent diet, or they had too much biofilm. They didn't have control in home care. And I started to look at these and go, well, if you can just identify the patterns, which are pretty easy to do, it makes it a lot easier to start doing caries risk management. So I published this paper back in 2013. I call them the usual suspects, but we did this based on data from over 12,000 patients that we collected caries risk assessment forms from in 6 different dental practices around the country. And the self-reported, number one self-reported risk factor for dental caries on these forms was saliva. 63% of the patients identified that they were either taking medications or that they felt like they had a dry mouth at some time of the day or night. 55% of the people said that they either snacked too frequently or they were maybe eating too much sugar. When we looked at the biofilm, 46% of the people identified that they noticed a plaque buildup on their teeth. 51% of them had a high Caries screen score, which is one of the biometrics that I helped develop and that we use. And we know from Alex Vera, I asked him this question directly, on a population level, genetics plays about a 9% role. Now, on an individual level, that could be much greater than that, but we know just in general, genetics plays about a 9% role for the public. But at the end of the day, it all comes down to Kaiser Sose, if you saw the movie. It's all about pH. This is a pH-driven disease. So, first step that we do here is Caries risk assessment, and we all want to get to the bottom of this form, and we want to fill out, circle this at a D0601 or D0602. We're all about the diagnosis, and the real point of this form, as my friend John Coyce would tell you, this is where you play Columbo. The value of this form is not having the D601, 602, or 603. If they got cavities, they have the disease, they're high risk. The value of the form is those top questions tell us why they have. Why does this person's mouth look like it does? Why does this person have cavities? So the most important part of this form is why. If I can get that why question correct, then I have an opportunity to help coach them to make them healthy. So if we look at this form, and this is the 12th version that I've helped develop over the last 20 years, and we took John Featherstone's data with his permission, and we developed this form, and we made it so that the patients are self-reporting their risk factors. That changes the psychology completely. If you've ever had the experience where you tried to convince a patient that they had something they didn't think they had, you're never going to win that argument. However, when they tell you, yeah, I feel like I have a dry mouth. Hang on, and my battery is running low. Oh goodness. And I need a power plug. Jenny, if you're listening, can you bring me a power plug for my IBM computer, hopefully? I need a power plug. Yeah, if you could get that. If we look at this and you only have green answers, you're low risk by definition. If you have one blue answer, at least one risk factor, you are moderate risk by definition. And if you have at least one red answer, which is a disease indicator, you are at high risk for this disease. So when we look at this form, we start with the saliva. What do these patients look like? And when I'm talking about risk patterns, what do these look like? So 63% of the patients reported that they were high risk for dental caries. Excuse me while I plug in. Did everything else but that this morning. Okay. There we go. We're back in business, folks. The top 2 questions, they self-report. Number 1, do you take any medications? Medications are the primary cause for dry mouth or hyposalivation. And then, do you feel like you have a dry mouth? I mean, you see these patients that you have to peel their cheeks off of their teeth just to be able to do an exam, so that's an issue. So here's a new patient. She's referred to me by another doctor. She's 42 years old. She comes in. She's been suddenly developing in the last 5-6 years, 2 new cavities per year. And they don't know what to do, and so I asked the patient, I go, well, what did they tell you? What did they think was causing this? And they said, well, I need to brush and floss better. Now, ladies and gentlemen, I want you to look at this patient's mouth. Number one, she has plaque control. Like I mean, she could compete with any of my hygienists on plaque control. You know, you're not going to win this battle for this lady with a brush and a piece of string. She doesn't need that. That's not her problem. What do you see missing in this picture? She doesn't have any saliva. I mean, saliva should be pooling in the vestibule. It should be bubbling from the teeth. It's hard to get inaural pictures on a person who has adequate saliva. This lady has none. So this is really a point, and her challenge was she was taking 2 different medications for anxiety. That Wellbutrin was one of those, which creates a tremendous dry mouth. So this is a function of, we need to be able to identify that. 70% of Americans are taking 1 or more medication per day. 50% are taking 2 or more. 20% take 5 or more. And I got to tell you, I mean, you guys see these people, they come in with a whole page of medication. Some of them have 2 pages of medications. And it's like, and then you have to pry their cheeks off their teeth, and then we wonder why they have all these cavities, all these lesions. So saliva, what do they look like? They're either taking medications and they just don't have enough saliva. So they have a dry mouth. You can tell just by looking in the mouth that you've got that issue. When we talk about diet, and I got to tell you, I honestly believe if we could answer this, ask the question better, and the patients could truthfully tell us the answer, this is probably the #1 cause for dental caries in the United States, because Americans eat a tremendous amount of sugar and we eat way too frequently. We have the worst diet patterns and behaviors that I can imagine. And so the questions here are, you know, do you drink liquids other than water more than 2 times a day? And do you snack, you know, during the day as well? You know, we know that sugar sweetened beverages are a huge issue in the United States. And I want you to take a mental photograph of this picture. This is what sugar looks like in the mouth. When you see decay just everywhere, not just located on the occlusals or not just here or there, when you see decay just located all over the mouth, they may not have enough saliva, they may have other things going on, they may have poor plaque control, but I guarantee you this is what sugar looks like in the mouth. So take a mental image of this, because this is what it looks like. Americans eat 23 teaspoons of sugar a day. Your patients eat 23 teaspoons of sugar a day. You know, and if you got vaccinated, I heard yesterday, if you've been vaccinated for the COVID and you have proof of that, you can go to Krispy Kreme and get a free donut every day. Like, that is really going to help our health in the United States, as if we don't have a problem already. Now, I'm appreciative for Krispy Kreme trying to do something positive, but quite frankly, you know, we're already eating too much sugar. Americans eat 51 pounds of high fructose corn syrup per year. We're #1 in the world. By the way, #2 is Mexico, and they eat 30 pounds. We are off the charts on our sugar consumption. This is a learning aid. Here's what 23 teaspoons of sugar look like. Now, I really want you to go home and do this. Take a baggie and put 23 teaspoons of sugar and look at that. Who in their right mind would sit and eat that? And we hear from the World Health Organization, we should be eating, honestly, you know, 3% of our diet should be sugar, you know, per day. That equates to 2/3 of 1 teaspoon. It's this little tiny bit on the bottom of this bag versus this huge bag here. These are great learning aids for your patients as well, because you know, it's shocking when you look at it directly. So diet, you know, they're either eating too frequently, they're eating too much sugar, but this is what sugar looks like in the mouth. You know, the carious lesions are distributed everywhere. If you have a biofilm issue, you know, here's the biofilm. Patients notice plaque buildup, or I use the Caries screen also. That's an opportunity in this form. But, you know, typically you see patients, they have a lot of biofilm on their teeth. They have a lot of plaque and they need help with their home care. Now, again, they may not have enough saliva. They may be taking medications, or they may have a bad diet as well. But when you see this amount of plaque on the teeth, you know that one of the areas you're going to need to work on is home care and plaque control with that patient. We now know in that biofilm there's over 60 different pathogens that we've identified. Most recently, Candida appears to be, you know, in the last 5 years, particularly in children, we see that Candida, for a long time we thought, you know, oh, that's interesting, Candida, it just happens to be here. I don't believe in biofilms anymore. There are no coincidences. If something is available or is present in the biofilm, it has a role to play. It's not there by accident. There are no coincidences when it comes to biofilm. So we know that Candida plays a role here. It's strongly acid uric, so logically it would play a role. So the biofilm, you know, typically patients look like that, and we go from there. When it comes to genetics, you know, there's not really a place on the form for genetics, because I can't yet measure your, you know, genetic profile. I think that probably is coming. I mean, we're talking about that, you know, in medicine. being able to identify certain genes. Certainly for breast cancer, we're collecting better and better data to know the risk that people have if they have that genetic profile. And we may see that in the future in dental caries. I mean, I wouldn't be surprised 10 years from now, we might have a chairside test for that. This is the only pattern that you're going to see on patients. It's a lysyl-2 enzyme. It's a bacteriolytic enzyme from the submandibular glands. And when you have a mutation in or a different polymorphism, excuse me, in that lysyl-2 gene, these patients end up with decay only in their mandibular incisors. Now, when I first read that study in 2013, I thought, nah, I don't buy that. That doesn't pass the smell test, right? I've never seen a patient that only had decay on their mandibular incisors. These are the most protected teeth in the mouth. These are the last men standing. If a patient only has 6 teeth, which ones are they? Like, we all know the answer to that question. And so the fact that these would be the only teeth that had decay, I'm like, nah, I don't buy that. 2 weeks later, this patient was referred to me by a pediatric dentist. She's 12 years old. Those teeth have been filled twice. The mandibular incisors, you can see the restorations and the leakage there. They're needing to be restored again. And, since I didn't know what I was looking at. Since I've seen this patient, I've seen 2 more since then. So if you ever see this, it's a genetic issue. You may not remember specifically what it is, but it's genetic. Send me an email and I'll help you work through that. This is a paper from Brian Novi. And this came out a few years ago talking about determinants of our overall health. And we know that genetic predisposition plays a pretty big role in our overall health. But behavioral patterns, that big blue wedge at the bottom, that's the participatory part of the, P4 medicine. And the challenge for us is that little orange wedge on the side, that's healthcare. We play a 10% role in people's health. And that's why it's so challenging for us to get the results that we think that we should be getting. Genetics, it's 9% based on the population. It's not as significant as I kind of thought that it would be, but it has pretty specific patterns. So next up, then we go into like our caries risk assessment. We get out the form, and when I first started doing this 20 years ago, I made the mistake of putting it in the hygiene operatory and having the hygienist fill it out kind of as a survey, a questionnaire with the patient. That takes way too much time. Hygienists are superhuman beings. How they do everything that they do in 1 hour, and we keep adding more responsibilities and more tests and all this stuff, and that needs to be completely revamped. The 1 hour hygiene checkup appointment is antiquated and needs to go away. We need to change that. All you hygienists that are on today, you have my greatest respect. I can't imagine how you do everything you do all day long. But I made a mistake of putting this form in that format into the hygiene appointment. It doesn't work. And number 2, we're much better off having the patient take it out, have the patient fill it out, and bring it in self-reporting those risk factors, because now, again, it changes the whole dynamic and the psychology. And that's when caries risk assessment really became more successful in my practice. When I talked about being predictive, this is one of John Featherstone's studies from 2015. We know that their baseline dental caries level is predictive of future disease. And so their caries risk out of the gate is predictive for future disease as well. So we have a baseline that's predictive. We know that it's preventive. I don't have time to share all those studies today, but we know that it's preventive. Then it's like we need to make it personalized to the patient. And that's this whole caries diagnosis. You take all of your data, you take your experience, if we're talking about evidence-based dentistry here, you take your experience with the patient, you take the results of your intraoral exam, your risk assessment, you look at the radiographs, you look at all of that, and then you take into account the patient's needs and wants and desires, the best available treatments, and then also your clinical judgment and experience. And then we come up with a diagnosis. For us, we're using this caries risk assessment form. This is free to you. And if you want to do caries risk assessment, you have to have a risk assessment form. I mean, you have to standardize this so you can track it. It helps you as you're approaching the patient with talking about behavioral issues. How can you help that patient? How can you coach them through making some changes? You need to know what those problems are in the first place, and we need to standardize it. So again, we talked about, they're moderate, low, and high risk for dental caries. Then we get into, well, now what do we do? Okay, now we know it's causing and driving their disease. Now what do we do about that? Well, I like to break things down into 3s. So we've got reparative ideas and strategies. We still need to drill and fill those cavities that are cavitated, right? Those lesions that have holes in them, we have to restore. you've got therapeutic strategies, and then you've got the behavioral issues that we need to be able to help the patient with also. And for most of us, we're not trained in dental school or hygiene school or dental assisting school how to help somebody change their behavior. Like, that's not a part of our curriculum. It's starting to be, like, the motivational interview or the wellness coaching, behavioral coaching and management. That's starting, but that's I went through a whole coaching program just to learn how to do that. But that's coming into our profession. But that's kind of the piece next that we need to get beyond the drill and fill. So you can remineralize with either fluoride or nano HA. And again, we've still got to do some drill and fill dentistry. I mean, we can't avoid that. When we talk about remineralization, the thing that appeared to have the greatest effect, and I think this is probably standard of practice for all of you in your practices, is 5% sodium fluoride varnish. That still is the best delivery vehicle for fluoride, and it's the only thing that had additional benefit over just 1,100 part per million fluoride dentifrice in this study. So fluoride varnish is the best way to use that. This is a panel of experts. These are people that I know well. Doug Young, who's one of our CariFree co-op members, Margarita Fontana, this entire panel. They looked at they created 11 recommendations for non-surgical treatment for dental caries. And these include the use of silver diamine fluoride, which I'm going to touch on just for a moment. You should all have that, in your toolbox. Sealants, again, we're underutilizing sealants in the U.S. by survey. 5%, sodium fluoride varnish, acidulated phosphate fluoride gel, 5,000 part million fluoride dentifrice or a gel, amongst others. They also recommended against the use of 10% CPP ACP in terms of treating dental caries. And you'll see these other studies like this then that come up with the same recommendations. You see those same 4 or 5 ideas over and over again. When we talk, so we talk about therapeutic strategies, I really look at fluoride, antimicrobial, xylitol, pH strategies, nano HA as a remineralizing agent, and sodium or silver diamine fluoride. And then we've got probiotics. We've got some things coming out of the market like molecular iodine, nano silver. We got some of those things to look at, but these are the things that I'm focused on at the moment. A good question is fluoridated water. Now, I live in Oregon, and so there isn't a ballot that goes by that doesn't have, it seems like, a measure from some community that wants to remove fluoride from the water. And it's been a valid question to ask because, when we introduced fluoride into the water, ground zero for that was like Flint, Michigan in 1945, and we've been, fluoridating the water in our community since then. But we didn't have the exposure. We didn't have the fluoride dentifrice. We didn't have fluoride rinses, fluoride gels. We were giving fluoride varnishes and fluoride treatments, and we didn't have this huge exposure to fluoride. So the question becomes, well, is fluoride in the water still even valid? Do we still need that based on all the other fluoride that we have and that we're exposed to? And the CDC estimates that it still reduces 30% of the decay in primary teeth and 12% in permanent teeth. So, those are numbers that are still important to us in terms of reducing decay. So water fluoridation still matters. We talk about antimicrobial strategies. I started with chlorhexidine, I moved to iodine, and ended up with sodium hypochlorite based on a lot of work by Jorgen Slotz in periodontal treatment. And so we developed a rinse. It's the only sodium hypochlorite rinse on the market to treat dental caries that I'm aware of. And we did this study in Queensland, Australia, Townsville. We looked at 2 schools that were high risk for dental caries over a 3-year period of time, and the carie-free treatment rinse reduced the decay frequency incidence in that population of kids by 73% over 2 years. That was just a supervised 30-second rinse at school 4 days a week, 9 months out of the year. So we know that sodium hypochlorite is a good and effective antimicrobial agent for this. Xylitol, there's been a lot of questions, a lot of resistance to xylitol as well as fluoride, amongst our patients. I would tell you, this is the exact study. The exact study was first published in January of 2013. It was a multi-site study looking at about 700 adults, and all they did was give them 5 xylitol. They were all high risk for dental caries. They gave them 5 xylitol minutes a day, and at the end of the study, there was no outcome. And so all the anti-xylitol people. This was in the news. It was in the New York Times. It was on Good Morning America. Xylitol doesn't have any effect. It doesn't work. And we've got a lot of studies with xylitol gum, et cetera, mints that we know show some help and some improvement. They went back and did secondary analysis of their data in this study, and they pulled out just the patients who had root surface lesions. And in those adults who had root surface lesions, those 5 xylitol mints a day reduced their caries incidence by 40%, which is huge. And so again, we need to target, when we talk about the 4 Ps, we want to make this personalized. So we want to personalize our strategies to the patient that's going to have the greatest effect for them. So I know that xylitol is very helpful in terms of root caries. Now, we talked about pH earlier today. I keep telling you that this is a pH-driven disease. And again, this is Philip Marsh and I had a meeting, Caries meeting a couple of years back. And Philip has, over the years, done studies and looking at models by just raising the pH in the mouth. And so that's one of the things that we started with, based on his work way back in 2001, designing products that were alkaline. And there's only a couple of products, alkaline dental products available. So this was really, we know that this helps and it works. And so modifying the pH of that biofilm, getting the biofilm to behave in a more healthy manner, we know is important. We also know, and I've been saying this for a long time, that the increased pH, also drives remineralization, and this study proves that. And this is just chemistry. I mean, remineralization is chemical, and so raising the pH, increases remineralization. And we'll leave it at that. But now we have studies that actually prove that as well. And the building blocks for your enamel are actually nanoparticles of HA that are on average size 20 nanometers in size. And it isn't like enamel doesn't melt, it doesn't become ionic and then suddenly re-solidify, recrystallize. It actually, these little building blocks, like little Lego blocks, come out of the enamel in the demineralization, and then they go back into the enamel during remineralization, like taking a Lego block out and putting a Lego block back in. And that happens with every crystal in nature, and it's called reoriented attachment. And that happens, and John Coyce and I published a paper in 2013 also on remineralization, studying the crystalline physics. And this was the paper, and we actually studied, and this was the paper that we tested and designed the CariFree gel with nano HA in it, finding the optimum levels between nano HA and fluoride, which I was told you couldn't put together, and that turned out not to be true as well. So you can put those both in a product, and it worked extremely well. We talk about silver diamine fluoride, and again, I encourage you all to have that. That's an important strategy that you should use. The one thing there's 2 things that I think are really important. Number one, take a look at the picture on the right. This is what happens when you use silver diamine fluoride on a carious lesion, enamel lesion, as well as dentin lesion. They turn black, they turn jet black. And well, they're already brown in my mind, so now they're black, but at least we're retarding the progress of the decay on those teeth. Now, it appears that in an enamel lesion, we might be able to, I hate to use this term because I'm not really sure that you can arrest dental caries on these lesions. That's a term I'm not really comfortable with anymore. And certainly in a dentin lesion, you are not arresting these lesions. I've had the clinical experiences. They become very hard on the outside. You think you've got them arrested, and a year later, that lesion is progressing underneath that black hard surface. And I had a number of teeth on patients that I was phasing their treatment. And as I went back to restore those teeth, I ended up having to extract them because they were decayed all the way through the tooth. So once you've had that experience, you realize that, okay, you're not arresting deep dentin lesions. A better approach might be to just spoon and scoop out atraumatically that soft decay, then treat it with silver diamine fluoride, and then maybe put a glass ionomer restoration in that. I think Doug Young and Alan Wong published a study in JADA a couple of years ago that was very impressive. So I think that's probably the best approach here. I just want you to, it's not a cure-all. I just want you to be judicious and use it. You should definitely have it and use it, but I question whether or not arrest is a term that we should be applying with this. Next up, probiotics, and probiotics have done a great job of being marketed to hygienists. I get a lot of questions from hygienists about probiotics. Unfortunately, most of the studies I see on probiotics indicate that they either had no outcome or they actually, the probiotic happened to be acidogenic, aciduria, and joined the party, which we know these organisms tend to do. And so they actually made the dental caries worse. Now, with the exception, and most of these studies come out of the Scandinavian countries, but with the exception of probiotic milk, I have two really good studies on probiotic milk. One, that daily consumption of probiotic milk on adolescents, grade school children, reduced their decay rate by almost 1/2. And then this other new study that was just published recently looked at not only daily consumption of probiotic milk or even 3 times a week on these kids, appeared not only to reduce the decay frequency, but it actually appeared to remineralize and help uh, again, delay the progress of those lesions on those teeth in those kids. So probiotic milk, yep, the evidence is there, it's solid. If you want to recommend that, I say go for it. But I would tell you, if you want to try some of the other probiotic strategies, do, but just don't make that your only strategy. Just don't depend upon probiotics, because we still got a lot of work to do, I think, in that product line. When we come down to behavioral issues, we have things that are modifiable theoretically, and then we have things that are not modifiable, right? So, the question is, does toothbrushing work? Does flossing work? The uh, landmark studies on this were done by Alice Horowitz back in the mid 1970s. Supervised toothbrushing and flossing at schools made no difference in the outcome. So literally, if we have other issues causing this disease, if it's the fact they don't have enough saliva, just brushing your teeth twice a day isn't going to maybe solve that problem for a patient, or if they're eating too much sugar. So we need to look at that. However, this is a study, and there was a large cohort, 99,000 kids that came out of Scotland, and when they were taught to brush their teeth in preschool, it reduced their decay rate by a third by the time they were 15 years old. So over a long period, this study went on for about 20 years. And so we know that toothbrushing is helpful. Obviously, it's logical. I'm going to tell you it's not. Unfortunately, we don't have a lot of great science to back that up, and the same with floss, but we do have some studies. And so it's important. And yes, we do need to recommend brushing and flossing. When it comes to like diet, I talked about earlier, the World Health Organization says, well, if we were being honest, we shouldn't consume more than 10% of our caloric daily intake should come from refined carbohydrates like sugars. Well, and then if we're being really honest, it shouldn't really be more than 5%. And then if you read the paper, and if we're being really, really honest, it shouldn't be more than 3%. And that's when we get down to the, 2/3 of 1 teaspoon of sugar per day versus the 23 that Americans are currently eating. So this is the challenge. We know that sugar is a huge issue, and I have studies as both the amount and the frequency. I have studies that indicate that both of those play a role. We know that saliva is important. Saliva is the major protective mechanism for your teeth against dental caries. The minute you start to eat, your body releases stimulated saliva, which has an alkaline pH. It's already trying to protect your teeth. So we know that saliva has a huge role here. Saliva is a very complex solution. It's elegant when you start looking at how much is there and how beautiful it is. Um, but we know that medications, and in this study, 70% of the people identified that they had dry mouth as a result of the medications they were taking. So I feel pretty comfortable with my data at 63%. That's probably conservative. But again, we know medications are an issue. You can't take people off their medications. So we need to be able to help them adjust and mitigate around that. When we talk about diet and home care are potentially modifiable, right? I don't know if you've ever had the challenge of trying to change your diet, or maybe it was a challenge for you to try and start flossing at some point in your life earlier. But new behaviors take time. It's not 21 days. It takes can take 6 to 9 months with daily reward and recognition and et cetera. So the motivational interview, that whole behavioral approach to dental caries in this study, it was very effective, more so than traditional drill and fill. So we know that motivational interviewing or behavioral coaching, wellness coaching, whatever name you want to give it, we know that that's effective. So coming up on the finish line here. So where does this leave us? We started today talking about these usual suspects. 63% in our data, 63% of patients self-reported that they didn't have enough saliva or they were taking medications. Diet was 55%. Again, I think if we could ask somebody, how many teaspoons of sugar do you actually consume per day, or how often, how frequently do you eat, that number could be much higher. It could be 70 or 80%. Um, and the biofilm we know is an issue for for at least half of our patients. We know the genetics is there somewhere playing a role in the background, but at the end of the day, it all comes down to pH. So when we talk about what kind of strategies, the suspects, now we get into that personalized part, you know, what is their problem? Like, why do they have this disease? What are the driving risk factors that are contributing to their disease? Then we're going to make recommendations based around those risk factors. We're going to personalize it for the patient. If they don't have adequate saliva, you want to make sure they stay hydrated with, by the way, neutral water. Half the bottled waters have a pH of 4, so I don't want people drinking that all day long. They just will drink diet soda at that point. We want them to drink, alkaline water, neutral water, or tap water. And we want them to at least try and neutralize after they've eaten or had a snack. This is somebody that you may want to recommend xylitol gum, xylitol mints. So we have different the xyli melts. I mean, there's all different opportunities we have to help that person. If they've got a dietary issue, again, then that becomes the participatory part of this as well. And we need to be able to counsel them on either their dietary pattern, they're eating too frequently, try and consume things. We have the sippers. They'll have the cup of coffee with the creamer and the sugar in the morning, and then they sip it all day long. They never get above the blue line. Their mouth never has an opportunity to recover. So it's really important for them to understand, hey, you want to have 2 cups of coffee? Gulp. Don't sip. Get it done in 15 minutes. Drink your coffee, get it over with, and then neutralize your mouth. But don't sit and sip on it, or even worse yet, sip on a big gulp of a regular soda or some other sugar sweetened beverage all day long. And then to also talk to them about just their overall sugar intake, just to be aware of where these free and hidden sugars are in their diet. When it comes to biofilm, we want to talk about, if they have a biofilm issue, we may want to recommend an antimicrobial strategy. And then we also need to talk to them about their home care and their, plaque removal. And at this point in time, it used to be I would always want to make the recommendation, we should do this first, we'll do that. And what we know from behavioral coaching, most important part is to let the patient pick the pathway because that way they're going to be most successful. And then genetics, again, you just want them to understand the risk factors. So that my protocol for the low risk Caries patient, these people are healthy, they have no risk factors, they have no disease. I just want them to stay healthy. They just need to keep whatever it is they're doing, they need to keep doing it because it's working for them. This isn't always in my practice. I always do a Caries risk assessment, fill out that form once a year. I do the Caries screen once a year on every patient. I'm going to offer them fluoride varnish, I'm going to offer them other strategies, and I want to educate them about risk factors. For the moderate Caries risk patient, I want to figure, again, the risk assessment form, the Caries screen. Now I'm going to recommend things. I'm going to recommend the fluoride varnish at least twice a year. I'm going to recommend seeing them twice a year for recall, and I'm going to recommend some other strategies: pH, xylitol, nano-HA, fluoride, etc. And I'm going to educate them about their risk factor and then target their specific risk factor and help coach them through ideas on how they might mitigate their risk. And then the high Caries risk patient, you throw the book at them. Again, on these patients, I want to see them every 3 months. I'm going to do fluoride varnish on them every 3 months. I may do the Caries screen on them every 3 months. Again, I'm going to always recommend these products now that have pH strategies, xylitol, nano-HA, 5,000 part million fluoride. I may or may not use an antimicrobial strategy depending upon whether they have a biofilm issue. It may be a saliva issue that's their major problem. And I may or may not recommend silver diamine fluoride depending upon where the lesions are located and, again, the needs and the wants and the desires of the patients. But this is really, it comes down to, for most of these patients, it's behavioral coaching. We're going to target their risk factors and we're going to help them develop strategies on how they can mitigate those. So I want to tell you today, I talk really fast. I had a lot of material to cover. We successfully covered it. I hope that you now look at delicate. When you see a patient with cavities, I want you to think out of the gate, why does this patient's mouth look like this? And then number 2, this is the mantra: saliva, diet, biofilm. Like, I want you to just sit with the patient and go, do they have saliva? Mentally, Do they have saliva? Does it look, do I see the sugar pattern in the mouth? Do they have, too much biofilm, too much plaque buildup? You just start to look at these issues. And then when you get to the Caries risk assessment form, which by the way, copy the Caries risk assessment form, when you text this number now, two things, you can get this in a file format so you can print these. These are free. These are free to you. I encourage you, if you don't use a risk, you don't have one, get one. This is to start Caries risk assessment. This is all you need, but you need this to get started. If you're currently using a risk assessment form and you want to try this one, you're welcome to it. Also, this is a book that I published just this last summer. It's Why Me? It's the follow-up to the Balance book that we published back in 2012. And this one is really well laid out. And it's more of a how-to self-discovery journey for the patient. The first one was had a little too much science. This is really done well. I'm really pleased with the outcome. It's won 3 awards already for nonfiction, but these are free to you as well. So if you text that number, you can have a free webinar that follows up with your team on Caries risk management. You can get a free copy of this book. So that's all free to you. So that's it for me for now. I think we're going to take some questions, and then I know, Sharon, that you've got the CE code for everybody. So thank you, everybody, for your time and attention. I really appreciate it.
Oh my goodness. Thank you so much, Dr. Kutsch. And thank you everyone for sending in your questions. We have so many questions coming in that we're not going to be able to get to all of them. We'll answer a few here, but know if you sent a question in, excuse me, that we will have Dr. Kutsch answer it after the webinar, and we will send it in our follow-up email. So be looking for that. Okay, Dr. Kutsch, so I'm just going to start at the top with these questions. The first question is CariFree something we can get for our patients as a take-home prescription to give at their appointment? We send high-risk patients home with ClinPro 5000 at the time of their appointment and find it works great when the patient can actually leave with the product. If they leave without it, a lot of times they don't actually use it. Can you speak to that?
Yeah, absolutely. And most of the practices that use CariFree products have them, and they dispense them directly to the patient. So the answer to that question is yes. So the patient can go and get most of the products either on Amazon or from CariFree directly from our website. But I would encourage you, you made the correct observation. 51% of prescriptions written, now this is across all lines of medicine and healthcare, 51% of prescriptions never make it to the pharmacy. So giving somebody a prescription and saying, here, go get this filled and then use this product, half of them are never going to get it filled, and half of those that get it filled may have never even use it. So you have a much better opportunity for success if you can actually put the product in the patient's hand, talk to them about how to use it, and maybe even have them use it, demonstrate it for them in your office before they leave. Because my own clinical experience, that was the most successful approach.
Excellent. Thank you so much. Our second question here is, what is your opinion, or how does sipping on sugar-free water or diet soda, does that increase caries as well?
Yeah, well, so that's that's a great question as well. And I will tell you this, that we want to create a healthy balance of the pH in the mouth when we go back to that siphon curve. So if you're sipping on acidic anything all day long, even if it's water that has a pH of 4.0, and you can go Google this, pH of bottled water, because every brand has been tested numerous times. And so there's a lot of different areas or locations that you can go to get that data. It's easy to go to Google and search that. But continually sipping on something acidic is going to train your biofilm. It's going to select for, based on Philip Marsh's work, that's going to select for acidogenic, acid uric organisms, and they'll predominate in your biofilm, and that'll could lead to dental caries. I had a dentist, had a great diet. This guy's a health nut, and he was he was sipping water all day long, and I asked him the question. He was developing decay. I mean, he was a practicing dentist, and he's like, "What's happening? I do everything right. I'm doing everything. Why am I? What's happening to me?" And we came down to, well, what are you doing? And he said, well, I sip on water all day long at work, and I'm trying to be real healthy. I'm stay hydrated. And well, what's the pH of the water? Are you drinking tap water? No, bottled water. Well, what's the pH? Well, the pH is 4.0. He switched to tap water, and guess what? His decay stopped. Period. So The other challenge with diet sodas is they also, when you get to that pH, they're erosive. So maybe not, we're contributing so much to dental caries directly because you don't have the sugar component. You do, if they're sipping on it, you do have the pH component, but they also cause tooth erosion, and we know that. So it's not just dental caries that become a problem with that, it also becomes tooth erosion. And actually, Rella Christensen did a really good study on that, looking at mineral loss on different liquids from milk to whatever, and sodas, teas, etc., that wine people drink, and they contribute to a lot of mineral loss, even a diet soda. So so that's a challenge too. Good
Excellent. Thank
question.
you for that. Yeah, I think we have time for maybe one, maybe two more. So the next question is there a coaching course for teams on caries risk management that you would recommend?
That's a tough one. I would say that I mean, I have my team here at CariFree train practices. They've trained, I don't know how many thousands of practices now on caries risk management. And part of that is that there are some behavioral coaching in there. There aren't a lot of behavioral coaching programs. I know Doug and I are going to do later this year, we're going to do a webinar, but you can't learn how to ride a bicycle on a webinar in an hour. So coaching is a whole different language. The best is Ferocia Knight in Portland. I spent 2 years in that program. I actually brought her into my office, my practice. We took days, and we spent probably 3 days in a coaching program with her, to learn the language, to learn how to help, talk to patients, so that we were asking the right questions, and that it was non-judgmental, and that we were being able to be more effective at helping them. So Ferocia Knight the name, I think, is Coaching World. It's in Portland, but again, there aren't a lot of, there need to be. That's a need. That's a huge need. So I'm thinking of Julie Kellogg and Walla Walla. And Julie, you should put together a coaching program for dental teams. Anyway, but again, you can get a lot of information from the CariFree team here too. So we're right up on the hour, Laura.
Did we have a
Jenny,
freeze? Jenny and Laura disappeared, it looks like. For those listening, and instead of looking at the screen, I'm going to read the verification code for you. It's the Coop 60 THECOOP 60. It's probably co-op, but I really like the Coop.
It is co-op, but
I do it every time.
But we call it the Coop,
So I always think of, chicken coop. So it's the co-op, THECOOP 60. And to verify, please log back into your CE Zoom account. You'll find this course on your dashboard. Click the green verify button and enter the verification code right there. Take any mandatory evaluations, and your certificate will be in your records under Manage CE. And please allow 72 hours for that to happen. It will probably happen quicker, but just give us 72 hours.
All right.
Dr. Kutsch, that was fantastic. Laura,
Oh.
Jenny, I don't know if you guys are coming back on. Dr. Kutsch, always an amazing
I just want
presentation.
to thank you so much, Sharon, for hosting and doing this and doing all this great work for us always. And I just want to thank everybody that attended today. Thank you for your time. I never take that for granted. And I hope that you got something that you can take back to your practice that can help you be a lot more efficient and more effective at being able to help your patients get healthy and stop having dental caries. That's been my goal for the last 20 years. So I wish you all well. And if I can be a resource in any way to you, please contact us. Thank you.
Thank you, Dr. Kutsch. Can you hear me?
I can hear you.
Oh, good. Okay, I'm sorry, you guys. I was sitting over there just chatting away, but apparently you couldn't hear me. So, well, on behalf of the CariFree Cooperative, we would like to thank you all for attending, and thank you, Dr. Kutsch, for another great informative presentation.
And just to remind everyone, we're going to be sending out a follow-up email, and that will have the link to the recording, the Q&A, information about our next webinar in April. You won't want to miss it. And don't forget to follow the CariFree Cooperative on Facebook, Instagram, and LinkedIn so that we can keep you up to date on what our great members are up to. There's a lot of helpful information posted weekly, so check it out. And I mentioned in the beginning that we had an announcement. So there is another reason why you want to get on and start following us, because we have a giveaway starting tomorrow where you can win over $2,000 of great items and services for your team. You'll all be receiving the details in your follow-up email, so make sure you open and read it. And there's some great items. Just to mention a few, there's a $500 Visa gift card. Who couldn't use that? Several coaching sessions available from our members, some really great educational material, and there's so much more. So all of these items, they've been donated by our co-op members, which just makes it that much more valuable. So be sure to enter to win. And again, thank you all for attending, and we'll see you in April for our next webinar.
Bye-bye, everybody.
Bye.